Thanks, Ravi. Thank you very much. I think you set the tone for the discussion between liver and kidney in the past session. So my focus is, of course, when I talk about the issues with failing liver graft, I think the liver, two of them, but it's more for the rest of the audience actually, because it's a very, I thought when this topic came, it's quite interesting because we don't discuss this so much even in our liver meetings. So it's something really interesting for me to talk about. So when we say, I mean, this is a situation which we don't want to be in, like in any transplant, with a failing graft, and especially in the liver when you don't have a good backup option for the organ, it is a very difficult situation. But it's not a sudden thing. If you look, I mean, we're just going to talk about deceased donor, live donors, early allograft dysfunction. This is a continuation. Failing graft is not one sudden event. Usually it's early allograft dysfunction, which could be mild, moderate, or severe, and the severe ones progress on to primary non-function, and that becomes a the final insult actually. So when we talk about this primary non-function, of course there were days when it was very high, the incidence, and then gradually now we are down to not zero yet. We're probably at 1.7 to 2% of primary non-function still happens. The situation is fast changing with machine perfusion, being able to resuscitate the livers in the bench, trying to understand if they are going to be viable or not, and then put them into recipients. So again, the primary non-function rate in this category of people is going to be much lesser in the days to come, but we yet haven't seen a series with 0% primary non-function. So DCDs, donation after cardiac death, which was probably in the early days, that was the modality of declaration, had a very high primary non-function rate. So people moved on to DBDs. Now we're back to DCDs with a good outcome, primary non-function still being less. So a lot has been understood over the years, and it starts not just with the graft. So it starts with the donor, the retrieval, the maintenance of the cold chain, the reperfusion, and in between comes the machine and the recipient's milieu. So it's a lot of things that put together to finally come to a point of primary non-function or not. So what happens pathophysiologically is one thing, but what happens during surgery on table is a nightmare, which I think all of us, all of us encountered that, because the more you do, definitely you're going to encounter it. It's a nightmare. The situation kind of unfolds from a stable patient, reasonably stable patient, or even a very stable patient. Once you put the liver in and do the reperfusion, you start things going out of control. The field itself will speak for itself. It will bleed so much, there will be small areas, wound, which was, until then dry, will all start oozing. The amount of blood products are going to increase. Your anesthetist is getting anxious. So the situation is not pretty. So it starts from intra-op, and primary non-function, if it's very severe or if it's imminent, it on table. But actually, most often it doesn't really evolve like that. It usually goes on to severe allograft dysfunction, and then there's a fine line when it slips into primary non-function or continues as severe allograft dysfunction or improves. So this is a continuum. Why is it so important to understand? Is because we need to take the decision of retransplantation. If primary non-function is happening or has happened, retransplant is the only option to save that patient. Whereas if it's early allograft dysfunction in the moderate or going into moderate, there may be ways to salvage that graft. Retransplantation is not an easy decision. In an elective setting, I'm talking about chronic graft loss, elective setting, the outcomes of retransplant is about 70%, which means 30% mortality in a retransplant elective setting. Again, there are high risk for whom we don't retransplant. 60 plus have a poor outcome with retransplant. Patients who have renal dysfunction associated with chronic graft loss have a poor outcome. So there are high risk you take out, and in spite of that, you have a 30% mortality. So what happens when you retransplant in an emergency situation, which is primary non-function? It is a very difficult call. Again, with graft availability and the outcome being poor. So this decision to retransplant has to come, the thought process when you start thinking of early allograft itself, a lot of things have to be set right if your outcomes of retransplant have to be good. This is an interesting paper where the outcomes of retransplant, they had 18 patients retransplant, of which 5 died retransplant and the rest survived. So they looked at the parameters which made a difference to the outcome. It's not so much the first part, sorry the slide is not very clear, but the first part which talks about the indication for transplant, the age of the patient, the donor type, whether it's split donor, DCD, DBD, nothing matters because all that is for the first graft, that graft has failed. Now what really matters whether this patient survives post a retransplant is how well is the patient metabolically maintained before the retransplant. And for that the PaO to FiO2 ratio, the base excess lactate. These are the important parameters which determine whether the patient survives post retransplant. Why are we stressing this? Because if we were to detect PNF 24 hours or 48 hours later, and in the meantime, if they have not been metabolically adequately maintained, they do not benefit from a retransplant. So this understanding is important because every aspect of this cycle is important to maintain good quality of the organ or to prevent early allograft dysfunction or PNF. Starting from the organ donor maintenance, the preservation, how do you optimize the recipient, what happens at surgery, at every part of the surgery, and in the postoperative period. So the first part of the cycle, of course, a lot of standardization is required, both when it comes to maintaining the organ donor, the retrieval, surgery, and how do you optimize the recipient. So the first 3 can go by SOPs. What happens at surgery and postoperative period has to be done irrespective of whether the graft is functioning well, not functioning, early allograft dysfunction or PNF. So adequate fluid resuscitation, wherever there's acidosis, go on to renal replacement at the earliest. Give good antibiotic and antifungal cover, exclude other causes of dysfunction because a sepsis picture can also present in a very similar way, severe sepsis. So you need to keep in mind all those aspects and periodic assessment every 4 to 6 hours. Now this continuum is very important because most of the definitions for early allograft dysfunction talk about different time periods which are like at 7 days. If you look at it, how do you define EAD? This starting from 1998 to 2010, they talk about the values at 7 days. What happens by 7 days? A lot has happened. And if it's going to progress on to PNF, you've lost the window period to make decisions. So what we need is not a one-point assessment of early allograft dysfunction, but a continuum, a different variable which can tell us right from day 1 that this is a patient, red alert, start watching out for. So models have been developed instead of just defining early allograft dysfunction. They talk about the models which incorporate several parameters including the lactate, the ongoing INR, and all of this put together. In fact, there are dynamic monitors using ICG excretion, which tells you exactly how the functioning of the liver in the functional component of it. And below a particular value, if it's not excreting enough, then probably early allograft dysfunction or PNF is imminent. So we need to move towards models which can tell us right from the immediate post-op which direction this patient is going, and that still remains a challenge. It is not as clear as it is mentioned here. All what we spoke about was from the deceased donor setting. What happens in a live donor? The parameters mentioned for early allograft dysfunction, like in the previous slide, talking about, let's say an INR, PT of more than 16. That's quite common in a live donor liver transplant in the first 2-3 days. It's not uncommon to see this. And you don't see AST in the 2000s in live donor liver transplant, whereas you see bilirubin go up. So the parameters used for deceased donor do not hold good for detection of early allograft dysfunction in live donor liver transplants. But at the same time, primary non-function is very uncommon in the live donor situation. What is important in a failing liver, early allograft dysfunction can fail also. So you need to understand in a live donor setup, PNF is not so much a problem, but early allograft dysfunction is a problem. So there have been parameters developed from Indian studies, Indian data to tell us how different LDLT is from DDLT when we talk about early allograft dysfunction. And like you see here, in the deceased donors, usually time of presentation is first week, whereas in live donors, usually a little later, because the graft has, the live donor graft initially, you can allow time because it's going to regenerate. You can allow the first few weeks to see how well it regenerates. So, but if it struggles through that period, you know this liver is not going to do well. So second week, and AST-ALT is not high, whereas in deceased donor that's very high. And here you have reversibility with early allograft dysfunction. If you do a lot of changes, especially let's say for example you have a small for size, you modulate the portal flow, you may be able to get that liver to recover better. So the intention to look at early allograft dysfunction in live donor is very different from a deceased donor setup. Now, is it just enough that we know the differences? We have data from India which tells us we can define them better with other parameters. Now, using the existing early allograft definition the definitions, the EAD mortality prediction has been pretty poor. So the Indian data has come up from ILBS, where they put together total bilirubin more than 10, INR more than 1.6 and urea more than 100 as a formula to predict early allograft dysfunction and mortality associated with that. It's not just predicting dysfunction, but who is the patient who's going to die, which means you probably want to do something better, maybe even offer retransplant for them. So I'm going to just draw all what we spoke about into a couple of case scenarios that we've had. Not easy decisions. I don't know if we have done the right thing too, but just I thought we could discuss and you could come up with suggestions. So this is a 58-year-old, low MEL score, was on the wait list for a deceased donor transplant, got an organ 8 months after listing, received a deceased donor liver transplant from a 28-year-old donor, cold ischemia time of 9 hours, warm ischemia time of 41 minutes. Based on this, it looks fine. 28-year-old donor, everything should go well. Unfortunately, intraoperatively, things were not looking pretty. Postoperatively, the first set of labs we get, AST is 8,000. 6 hours later, AST was 12,000. So here we are with a primary non-function from a 28-year-old donor liver. 12 hours later, he was on inotropes, RRT, all sorts of supports. His sugars were dropping, lactates were going up. We know it's PNF. We list him for a transplant. In the meantime, his son comes forward to donate, and he had a live donor liver transplant. The patient is doing well, close to about 12, 13 years post-transplant now. So this is a situation where organ availability, because the son came forward, was sorted out, and PNF was staring on our face, we could take care of it. But looking back, 28-year-old donor, cold ischemia time 9 hours, didn't look bad. On this, it all looks like standard parameters. So where did we go wrong? This is our paper on where we analyzed our 5-year outcomes of deceased donor liver transplants. So in this, I want you to just look at two aspects. Now, on the adult transplants, you can see the lower down, we mentioned primary non-function in 7 of our patients. In the pediatric, we had 2 with primary non-function. That's quite a high number if you look at it. But we divided our data into 2 time periods, from 2010 to 2015, 2015 to 2019. In the second phase, we did not have any primary non-function. This is just to say that there are a lot of other factors. We just can't go with just donor DRIs or other indices because they have all been derived from a setup which is very mature. We are still in our early phase in different parts of the country. Some programs are established with deceased donors, some are still evolving. So what we look at in terms of a donor risk index may not apply to, let's say, if you have the donor from a hospital which is declaring it for the first time, they may not have maintained the donor properly. We have young teams going out for retrieval. Things could be different. So it is not set in stone. A lot of things change, and we have to really anticipate and do things accordingly. Now moving on to case scenario 2, this is a 69-year-old who with a MEL score of 20. His main comorbids in the pre-transplant period was a borderline kidney function from hepatorenal syndrome. His peak creatinine was 1.8. Just before surgery, it was 1.3. We had a live donor from his family, his nephew, who donated, 46-year-old right lobe. Good graft on evaluation. At surgery, felt a little bit fatty, but on evaluation parameters were all okay. Now, first 5 days, bilirubin was static around 8, which happens in live donor transplants. But the creatinine was slowly rising for the first few days. He was not overtly acidotic, but creatinine was somewhere around 2-ish, making good urine still. On day 6, he has a bleed, had to be re-explored for the bleed. Bleed sorted out, came back to the ICU, but subsequently that hit on that graft. We started seeing the bilirubin worsen day by day. Renal dysfunction kind of sort got established. He had to go on CRRT. Now he's 2 months post-op. He's pretty cholestatic. We do plasma exchange. I'm not saying there's evidence to it, but we all at some point when the bilirubin hits 25, 30, you want to do something about it. So he's had plasma exchange quite a few times. His kidneys are pretty much shut off because when you go through all of this, you have to put them on antifungals and all of that. So he's been on CRRT initially, now on SLED. He was on ventilator with all of this, tracheostomies. Now he's down to just a Shileys. He's not on inotropic supports, has had cultures positive on and off, but nothing major, no major septic issues. So he's crossed that 6-week, 8-week period when the liver will regenerate. What do we do now? Do you think we can offer him retransplant? But all odds, as per data, 60 years renal dysfunction, even in a elective setting, they don't do well. Here is somebody who's not an elective. This is like semi-urgent, I would say. We don't know the answer. He's still in our ICU. I don't know the answer. Failing grafts can happen not just in the short term, long term also is a big problem. Not so much as it is in the kidney scenario. We don't lose grafts in the long term in liver so much, but every once in a while when we get it, we really are stuck what to do. Here's a 54-year-old, had a liver transplant 4 years ago for alcoholic liver disease, has been on reasonably low dose of immune suppression because he's had a very good graft function. He's on low dose Advograft because mainly his creatinine started kind of doing from 1 to 1.2 to 1.3. So he's been on Advograft, which has helped with his kidney function. And because his levels run around 3-ish, we kind of add an MMF in the long term to kind of balance it out. So he's had very good liver function, 4 years, AST running around 14 or 10, round about that range. About 2 months ago, he started having, like a viral upper respiratory and, stuff like that. When every time, like we all know, when there's an infection, the enzymes kind of do this up and down thing. So his enzymes went up 34, 40, 60, and then once again it came down to 24. So kind of hovering around there. And then there's a sudden increase in liver function test, bilirubin going to 14, AST, ALT to 1400. So this is clearly an acute hepatitis picture. And we do a biopsy on him and it shows severe plasma cell infiltrates in it. So it's a diagnosis between whether it's a de novo autoimmune hepatitis or is it a severe plasma cell rejection. It was not antibody mediated, confirmed with stains. So essentially we had to pulse him, get his TAC level up, all of that, with bilirubin peaked at 25 and then started slowly coming down. And then 10 days later, he's not able to really walk quite well when he comes into the office. Thought to be steroid-related proximal myopathy, but then we get him admitted because he was quite uncomfortable with it. Over the next few days, very severe low volume. He cannot even move. He had a CPK of 38,000. We get the neuro and everybody involved, and they thought it's probably autoimmune or TAC-induced myositis. So we are kind of stuck here. We had to switch him from tacrolimus. Billy, was hovering around 14 to 16. He had IVIG for myositis TP. In spite of all of this, I think we lost him in 4 weeks. So this is somebody who had a perfectly good function until 4 to 6 weeks ago, graft function, and then you lose him. So I don't know how we could have done better here. That's something, for discussion. This is the last patient. Again, kind of same time period as the other gentleman, but when they came to us, but this is somebody 9 months post-transplant, mainly because of non-compliance, medications, she had skipped every now and then. Biopsy showed a pretty bad rejection with early chronic setting in, bilirubin going up to 42. But with this patient, we got lucky with lots of, stuff that we could do, TPE, bortezomib, everolimus. Now she's 4 months later able to hold her graft with a bilirubin of around 2. So difficult situations, especially with a failing graft in long term in the liver, is always a difficulty to handle because you don't know at what point you lose control of that situation. Thank you very much for the opportunity.